All right, hello everyone. Welcome to the second peer-assisted learning renal lecture. My name is Matthew. Now I believe you've already covered AKI and CKD and a couple of other topics, and so today I'm going to take you through these things: renal acid-base control, hyperkalemia, nephrotic and nephritic syndromes, so some really meaty stuff, and also renal cancers just to finish off. So let's get into it by talking about renal control of H+. I'm going to talk to you about how the kidneys control pH. To do that, we're going to take a look at a diagram of the nephron, a bit like this one, but a bit simpler. And once we've done that, I'll show you a pathology of renal acid-base control. And the only one I could think of was renal tubular acidosis. So, in conditions where the blood becomes too acidic, i.e. acidosis, the kidneys have three mechanisms for controlling pH. First of all, they can secrete H+ into the urine. Then they can resorb bicarbonate from the urine back into the blood, and they can even produce new bicarbonate by the breakdown of amino acids. Now, all of these things go together to make the blood more alkaline or to increase the pH of the blood. And then it follows logically that in alkalosis, the kidneys can reverse these functions. They can retain H+ ions rather than excreting them, and they can stop the resorption and production of bicarbonate, and all of this will go together to lower the pH of the blood or make it more acidic. Now, of course, H+ isn't the only ion being moved around by the kidneys, and to understand how everything relates, we need to look at a diagram of the nephron. These can get very complicated and off-putting, but my hope is to show you a very sketchy kind of simplified diagram, which you might even want to draw out along with me. So here what we have is the afferent arteriole coming into the glomerulus here. High pressure causes filtration into the Bowman's capsule, and the remaining blood leaves via the efferent or efferent arteriole. The filtrate passes from Bowman's capsule into the proximal tubule, then into the thin part of the loop of Henle. From there into the thick ascending limb of the loop of Henle, then into the distal convoluted tubule, and somewhere around here that turns into the collecting duct. And I've given you a preview by accident, but there's lots of solutes moving in and out of the urine throughout the nephron, but we only need to concern ourselves with the movement of solutes at these four locations here. So, at the thick ascending limb of the loop of Henle, you have the resorption of sodium, potassium, and 2 chlorides. Notice here how all the charges balance out, and so nothing further to worry about here. Then up here in the distal convoluted tubule, you have the resorption of sodium and chloride. Other thing to note is that calcium is also resorbed in the distal convoluted tubule. However, this is under the influence of parathyroid hormone, and so it's not part of the mechanism that we're concerning ourselves with today, but may be useful for your MCQs. Over here in the late distal convoluted tubule, or some sources say the collecting duct, this is where it gets interesting because sodium is being resorbed by these cells, but in order to balance out the charges, they are excreting potassium into the urine. The cells that perform this function are called principal cells, and it's under the control of the hormone aldosterone. And then further along, these are the cells that excrete H+ into the urine. So this is your pH control step, and in order to balance the charges, they resorb some of this potassium. And these cells are called type A or alpha intercalated cells. There is, of course, a beta intercalated cell, and this performs the reverse function. So it resorbs H+ and excretes potassium into the blood in conditions where the blood becomes too alkaline and you need to recover H+. However, blood doesn't normally tend to become too alkaline. Blood tends toward acidity, and so in normal conditions, beta intercalated cell function is not required, and so we can forget about it for our purposes. It's really just there for the sake of completeness. And here is everything that I've just told you in text format, should you want to pause here. Okay. So if you know all of this stuff, it can help you understand stuff like diuretic drugs. All you need to know is whereabouts they work. So for example, thiazides like metolazone or bendro work in the distal convoluted tubule. Now that means that they prevent the resorption of sodium and chloride. The result of this is that you have a high sodium in this part of the nephron, and that causes the principal cells to overwork. They resorb a lot of this sodium and in exchange secrete a lot more potassium than usual. And then the high potassium here causes the alpha intercalated cells to overwork in a similar way. They resorb some of that potassium and as a consequence, they chuck out a lot more H+ than usual. And there you have all of the side effects of thiazide diuretics. So first of all, hyponatremia, low sodium because sodium can't be resorbed here. Second of all, hypokalemia because too much potassium is being excreted here. And lastly, alkalosis because too much H+ is being excreted here. And then we can look at another class of drug, loop diuretics. It's fairly obvious where they work, with the caveat that it's the thick ascending limb of the loop rather than any old part of the loop. So they are inhibiting this resorption of sodium, potassium and 2 chlorides. And the side effects are rather similar. You have a high sodium here. Now, with loop diuretics, you don't have the same degree of hyponatremia because this transporter can still resorb some of that sodium, but you do have principal cells overworking, and so you have hypokalemia, and you do have alpha intercalated cells overworking, chucking out too much H+, and so you get alkalosis. Now, conveniently for us as diagnosticians, there are also some genetic syndromes which can impair these cells in exactly the same way as the diuretics do. And what this means is you don't need to learn the symptoms of these particular syndromes because you just relate them to the corresponding diuretic. So for example, Bartter syndrome affects the thick ascending limb and it affects this resorption. And so patients with Bartter syndrome present to you exactly like they're taking loop diuretics despite the fact that they won't be on any. And then there's another syndrome called Gitelman syndrome, which impairs the cells of the distal convoluted tubule, and so patients with Gitelman's present to you exactly like they're taking a thiazide diuretic despite the fact that they're not. Alright, and then we can now add another layer of complexity to this diagram. So remember I said that principal cell function is promoted by the hormone aldosterone. And all of you have probably got this coming out of your ears at this point, that aldosterone is the end effector of the renin-angiotensin-aldosterone pathway, which controls blood pressure. So low blood pressure is sensed here in the glomerulus. Renin comes from round about here, the juxtaglomerular apparatus, and it cleaves angiotensinogen to Ang1. Ang1 travels to the lungs, where it's converted by ACE into Ang2. And angiotensin 2 promotes aldosterone secretion by the adrenal cortex, and specifically the zona glomerulosa of the adrenal cortex. So what this does is increase principal cell resorption of sodium. Water follows sodium into the blood, and that increases your blood volume, which increases your blood pressure. So that is how the kidneys and the nephron are regulating blood pressure. Now we can pull all of that together with the drugs we've already talked about and add a couple more renally acting drugs to get one big kind of master diagram of renal physiology. So first of all, let's add the potassium-sparing diuretics like spironolactone, eplerenone. These ones are very easy to understand. They inhibit the function of principal cells directly, and for this reason they're sometimes described as aldosterone antagonists. So they inhibit the secretion of potassium, so you end up with hyperkalemia, too much potassium, and they also inhibit the resorption of sodium into the blood, and so you end up with low sodium hyponatremia. And then the next couple of classes of drug we'll look at are the ACE inhibitors like ramipril and the angiotensin receptor blockers such as losartan. Now these ones are working kind of upstream of aldosterone in the RAS pathway, but ultimately what they're doing is impairing the function of aldosterone in a similar manner to spironolactone. And so there you have it. That is renal physiology and renally acting drugs all on one big diagram. So if you ever get stuck on do thiazides give you acidosis or alkalosis, hopefully you feel confident to just sketch this out and you'll be able to work it out in 1 minute. So let's get back to renal control of pH in a bit more detail. So we've already said it occurs in the late distal convoluted tubule in alpha intercalated cells. So if we zoom in on this particular cell type, we get a diagram like this, which I pulled straight out of a textbook, and it just looks horrendous, doesn't it? But don't worry, so the first thing to do as always is just simplify these things. So I've got rid of that stuff, and you can now see a bit more clearly that all that's really happening is that these cells are excreting H+ and resorbing some potassium, just like in this simple diagram here. Now, in order to separate out H+ from water, you need to react it with carbon dioxide and put it through an enzyme called carbonic anhydrase. Now this enzyme might be familiar to you because it's the target of another diuretic drug called acetazolamide. The reaction catalyzed by carbonic anhydrase is this one. Water plus CO2 gives bicarbonate and H+. And so what you can do, what these cells do, is excrete the H+, while resorbing the bicarbonate component back into the blood. And that's really convenient. It gives you a sort of two-hit method of making the blood more alkali, because you're losing acid into the urine while simultaneously reclaiming alkali. And that's it. That's renal control of pH in a nutshell. So before we move on, we'll just talk about renal tubular acidosis. And if you're anything like I was in the third year, you've heard of RTA, but are not entirely confident on what it is. Part of the confusion comes from the naming. So acidosis within the renal tubules is actually a good thing. You want to acidify the urine to get rid of acid. And what renal tubular acidosis actually means is acidosis in the body, i.e. metabolic acidosis, due to pathology in the renal tubules. And there are a few types of RTA. The first one is called distal tubule RTA, and this is very simply a failure of the alpha intercalated cells to excrete H+ here. Type 2 is called proximal tubule RTA. Now, I haven't mentioned it, but the proximal tubule is responsible for resorbing lots and lots and lots of things, and actually there's a list of it on slide 3 from the Oxford Handbook diagram if you want to take a look at that. And so this is a failure of the proximal tubule to resorb bicarbonate. There is a more global syndrome of proximal tubule failure where it doesn't resorb anything, and that's called Fanconi syndrome. And so type 2 RTA can be a component of Fanconi syndrome, or it can exist as its own discrete condition. Type 3 is a term that's no longer used. It used to mean a mixture of the first two types, but I think it was determined that it wasn't clinically useful, and so that's one less thing for you guys to learn. And type 4 actually has to do with aldosterone, so a syndrome of low aldosterone, such as you might see in Addison's disease, or resistance to aldosterone. So it impairs principal cell function. The principal cells can't excrete potassium, and that means that the alpha intercalated cells don't have as much potassium to exchange for H+. For that reason, this is sometimes called hyperkalemic acidosis. And so just to ram the point home, type 1 RTA affects the alpha intercalated cells of the distal tubule, type 2 affects the proximal tubule, type 3 doesn't exist, and type 4 affects aldosterone here. So that was renal acid base covered. So we talked about how the kidneys handle H+ in the distal convoluted tubule, how they separate it out from water with carbonic anhydrase, and the concept of H+ being exchanged for potassium. And to do that, we had a look at a diagram of the nephron, and we mapped on the function and side effects of some diuretics, and we've also just talked about RTA. Next up, we're going to talk about hyperkalemia. So we'll define it. You guys all know that it's a medical emergency, but we'll go into detail on why that is, and we'll take a look at some of the ECG changes, which are very, very sort of commonly tested on, very good to know, and quite easy as well. And then we'll talk about the management, so which steps we take, which order we take them in, and why. So breaking this down, hyperkalemia refers to hyper, too much, cal, potassium, emia in the blood. The reference range for potassium is given as 3.5 to 5. Some sources say 5.3 actually. But the thing to really be aware of is that a potassium of above 6 millimoles per litre is considered to be a medical emergency, and the reason for this is that it predisposes you to arrhythmia by making the heart muscle hyperexcitable. Now this can be visualised on the ECG by a very specific set of abnormalities, which we're just about to talk about. And if you see this ECG and you do nothing about it, the endpoint can be ventricular fibrillation and cardiac arrest. So this is just to illustrate the concept of hyperexcitable myocardium, what it really means. And a key thing to understand about hyperkalemia is that most potassium within the body is intracellular, so it resides within cells, and there's very little potassium free floating in the blood or the serum. The effect of this is to contribute to a gradient, and this gradient is helpful in generating the resting membrane potential of excitable cells, which is shown here by the blue line. The threshold potential, shown here by the red line, that's the level that you need to depolarize these cells to in order to make them fire off an action potential. Something from, I think, year 1 physiology. Now, the problem with having too much potassium in the blood outside cells is it actually decreases this gradient here, and that brings the resting membrane potential much closer to 0 millivolts, i.e. nothing in, nothing out. You can now see that's dangerously close to the level where these cells might start to fire off an action potential, and that's especially dangerous in myocardium, which needs to depolarize in a very synchronized kind of Mexican wave-like manner. You can't be having these ectopic action potentials firing off in random places because it leads to arrhythmia, and that is what is meant by hyperexcitable myocardium. So causes of hyperkalemia are quite easy to understand. First of all, just to say that it's very, very difficult to eat too much potassium. So even the banana, which is the most famously potassium-rich food, only has about 12 millimoles in it. But you can take in too much potassium in the setting of IV fluid therapy, so if someone adds too much potassium to your fluid bag. The second thing to understand, and this is why it's in this lecture at all, is that potassium is, of course, excreted by the kidneys. So anything that impairs the kidneys, including AKI, can rapidly lead to hyperkalemia. And then the third thing is this concept of extracellular shift. So as I've mentioned, most potassium is intracellular. Anything that allows potassium to leak out from cells into the blood, things like tumor lysis, cell lysis, can lead to hyperkalemia because it's the amount of potassium in the blood rather than in the totality of the body that we're concerned with. This is going to be a sort of summary revision slide. So excess intake of potassium only happens in the setting of IV fluid replacement. For this reason, there's a sort of industry standard, which is that the maximum rate that you're allowed to infuse potassium is only ever 20 millimoles per hour. That's the fastest you can ever infuse potassium. Now, for that reason, you can never put any potassium in a bolus of fluid, i.e. anything that you're giving 500 mils over less than 15 minutes. Never add any potassium because it's too fast. Second concept is impaired renal excretion. And so it can happen in the setting of AKI or renal impairing drugs, but also in the setting of low aldosterone. And the reason for that is our old friend, the Nephron diagram here. Anything that's impairing in aldosterone will have an impact on principal cell potassium excretion. So that includes the potassium-sparing drugs like Spiro, it includes ACE inhibitors and angiotensin receptor blockers, which are working upstream, and it includes genetic syndromes like Addison's disease or congenital adrenal hyperplasia. And lastly, extracellular shift. So burns, severe burns can cause cell lysis and rhabdomyolysis, the breakdown of skeletal muscle. Low insulin can also cause extracellular shift. This is because insulin is responsible for driving potassium into cells or increasing cellular uptake. And also metabolic acidosis can cause an extracellular potassium shift. So now let's look at the ECGs of hyperkalemic patients. So the first feature, you're probably aware of a lot of these already. The first feature to look out for is these tall T waves, sometimes described as being peaked or tented T waves. Next up, as the potassium increases to about 6.5 or beyond, you start to see P wave changes, the first of which will be PR prolongation. Now the P wave is measured from, the PR interval is measured from the start of the P wave to the start of the QRS, and anything beyond 5 small squares or 200 milliseconds is prolongation. And then the next thing that you see is complete loss of the P wave, and this is because of those ectopic action potentials firing off that we mentioned before. So at this point, you're losing any sense of synchronized atrial discharge. There's just, completely random firing of action potentials in the atria, a bit like with atrial fibrillation where P waves disappear. And if you allow it to continue, which you shouldn't, you'll start to see QRS widening at potassiums of 7 or even 8. I think this diagram's a bit extreme saying 8, but you'll start to see widening of the QRS beyond 3 small squares. And that can start to merge, the wide QRS can start to merge with the already tall T waves, and that can give rise to a sinusoid QRS or a sine wave appearance. And if this continues, crazy potassiums like 9, I mean, you should really never be seeing stuff like that, it can result in asystole. And I find that, talking about ECGs and looking at hand-picked single lead pictures from Google Images is one thing, but when you look at a proper 12 lead, it can be a little bit more intimidating. And so top tips are that the T waves are best appreciated, the peak T waves, in leads V2 through to V4. And P wave changes, it's really good to look at lead 2. Which is often also the rhythm strip. So armed with that knowledge, let's take a look at a proper 12 lead. What can you see here? Well, if you look in V2 all the way through to V4, you can appreciate these big, tall, peaked T waves, which we mentioned. So these are the first changes that you'll notice in hyperkalemia. Now, if I can bring you over here to lead 2, or maybe even to the rhythm strip, you can see that there's no P waves. So you've got absent P waves in lead 2, also lead 3. And this one might need the eye of faith, but if you come over to the end here in the rhythm strip, there may be some degree of QRS widening. I might have imagined that, to be honest, but eye of faith, and just be aware that beyond 3 small squares means QRS widening. And so one more trace for us to look at together. This is, I'm sorry, it's not a very good trace, but you almost don't need the little squares because you can just see this is grossly abnormal. And this, of course, is the ECG of ventricular fibrillation. If you see this, DC cardiovert is the treatment. So, to avoid a fate like that, we're going to look at the management of hyperkalemia. The first step is to give IV calcium gluconate. Now, everyone learns to parrot this line. Calcium gluconate stabilises the myocardium in hyperkalemia. But what does that actually mean? So to illustrate it, I brought back this diagram, and you've got your high, dangerous resting membrane potential here. Now, calcium is, of course, a positive ion, and through some electrophysiological magic, which is too complicated to go into now, what calcium gluconate actually does is it increases the threshold potential to a point where it's well clear of the dangerously high resting membrane potential, and that means that you're less likely to fire off those ectopic action potentials that we were talking about before. Importantly, notice that this does not change the resting membrane potential, and giving calcium gluconate doesn't have any effect on the level of potassium that's in the blood. To change that, what you need to do is the next step, which is give an infusion of insulin dextrose or insulin glucose. It's the same thing, and this causes potassium to be taken up into cells. So insulin, by acting on its receptors, causes cells to uptake potassium from the blood into the intracellular environment where they can do much less harm. Another drug that can achieve this effect is salbutamol, so that's a kind of lesser known effect of beta-2 receptors. It can drive potassium into cells also, but you do have to be careful with giving a nebulizer of salbutamol because a side effect is commonly tachycardia. Now, that, in the setting of myocardium that's already unstable, is potentially very dangerous. And so I've come across renal consultants who say, never give salbutamol for hyperkalemia, but equally I have seen it done on the ward, and it's part of the NICE algorithm, so I would recommend that you learn it, and perhaps you can make your own decisions about it when you come to practice. Lastly, we can just clean up this potassium that's left in the bloodstream, and to do that we give calcium resonium either orally or by enema. And this binds up the remaining potassium and encourages its removal from the body. Another way of doing this is by giving loop diuretics, which inhibit the resorption of potassium along with sodium and 2 chlorides in the thick ascending limb. But do be aware that a lot of these patients are only hyperkalemic in the first place because they had kidney pathology, particularly AKI, and for these patients you can give as much loop diuretic as you want, but you're never going to make their kidneys excrete potassium properly, and so for these patients it's very important to get them on renal replacement therapy early on, particularly hemodialysis. Before we move on, a quick word about hypokalemia. So this is the opposite pathology, and the ECG is almost a mirror image of what you get in hyperkalemia. So in hyperkalemia you get peak T waves. In hypo, you have flat T waves. You also get U waves, which are these small deflections at the end of the T wave, quite hard to appreciate. And then you also have ST depression and a prolonged QT interval, which reflect repolarization abnormalities in the ventricles. And the causes of low potassium are all the things that you give to cause excretion of potassium, obviously. So furosemide can cause hypokalemia. Increased aldosterone causes secretion of potassium. And also hypomagnesemia can cause low potassiums too. So here's an exam question for you guys. A 72-year-old woman has a potassium of 6.8. Her ECG shows tall tented T waves. What's the single most important next step? And the answer here, most important thing to do for this lady is to give calcium gluconate because this stabilizes her myocardium and protects her from arrhythmia. Insulin dextrose infusion is not wrong, and in fact that would be the very next step. But do be aware that before you start to cause all these crazy electrolyte shifts by giving lots of insulin, you must first stabilise the myocardium by giving calcium gluconate. So that's why that's the answer here. Okay, well done everyone. That was hyperkalemia. So we defined it. We talked about why it's a medical emergency with arrhythmia and the concept of a high resting membrane potential. We looked at the ECG changes, peaked T waves, PR prolongation, loss of P wave, QRS widening, sine wave, and eventually asystole. And we also looked at the management with calcium gluconate, insulin dextrose, salbutamol by nebulizer, and calcium resonium. So next we're going to move on to talk about nephrotic and nephritic syndromes. This is some really meaty, renal stuff here. So we're going to talk about what's the difference between the two of these things, barring one letter in the spelling, the most common causes of each of these two syndromes, and also how they typically present to you in the clinic, and also, of course, in your MCQs. So in order to become familiar with the difference between nephrotic and nephritic syndromes, I find it helpful to think about the difference between the conditions of nephrosis and nephritis. So first of all, nephrosis refers to pathology with the podocytes. Now these are the cells with the kind of foot processes, that's why they're called podocytes, which sit on the filtration barrier and make it a barrier. So anything that goes wrong with these cells can cause the filtration barrier to become leaky and permeable to larger molecules, in particular proteins, and that gives rise to what's called the nephrotic triad, which I suggest that you commit to memory. So proteinuria, quite large, more than 3.5 grams per day. Kind of as a result of that protein loss, low albumin, hypoalbuminemia, and kind of as a result of that, because albumin regulates your colloid pressure, oedema, which can be peripheral, periorbital, ankle edema, whatever. And sometimes hyperlipidemia is cited as a feature of nephrotic syndrome, but not always. Nephritis, by contrast, as the name suggests, is inflammation, itis, and damage, and this is kind of manifested in blood in the urine, which can be non-visible, you only pick it up on a urine dip, or visible, and previously this was called microscopic or macroscopic, but those terms are going out of fashion now. And there is a sort of loose cluster, a pentad, if you like, of nephritic syndrome, which I've got here, but important to say to you that this is not as clearly defined as the triad for nephrotic syndrome. It's essential to have all three of these to make a diagnosis of nephrotic syndrome, but you don't need all five of these really for it to qualify as nephritic. And there may be some proteinuria, but it won't be as massive as you get in nephrotic syndrome. Now, the inflammation can affect anywhere in the kidneys. If it affects the glomeruli, it's called glomerulonephritis, and if it affects either the renal tubules or the interstitium, it's conveniently referred to as tubulointerstitial nephritis. Just a word about red blood cell casts. These are an important thing to watch out for if you're trying to determine whether or not it's glomerulonephritis. When you pour something into a mould, like plastic or something, it has been cast by that mould, right? And so a renal cast or a urinary cast is actually, the mould for that is the renal tubule itself, and that's why it comes out in the urine in the shape of a cylinder. And urinary casts are made of this sticky protein called TAM-horseful protein and another component. And you can have red blood cell casts like you get in nephritic syndrome, but you can also have white cell casts in infection and hyalin casts in other renal pathology. The only one that we need to be concerned with is the red blood cell cast as a sign of nephritic syndrome. And this picture is just to remind me to tell you that although I've laid these two out as sort of very distinct separate conditions, they are in fact kind of more of a spectrum of conditions, because proteinuria and hematuria are not mutually exclusive. And so you get some conditions that give you a very nephrotic picture, pure proteinuria, some that give you a very nephritic picture. There are some conditions that can present with a range of these things, and then there are others that kind of sit right in the middle, and these ones can present some diagnostic challenges. So first of all, let's talk about some causes of nephrotic syndrome. So the most common ones are minimal change in children, FSGS in adults, membranous nephropathy, which is a weird one with autoantibodies, and membranoproliferative or mesangiocapillary, which is even weirder, and we'll talk about it shortly. So first of all, in the nephrotic category, we have minimal change disease. Now, this one is usually of unknown cause, and it's much, much more common in children. Now, the key investigation for this one is electron microscopy, so very, very powerful microscopy that can visualize the podocytes, and it shows effacement, which is kind of like collapse of the podocytes onto the basement membrane. That impairs the filtration barrier and lets protein leak out. This condition is easy to manage because it's highly responsive to steroid therapy. So you give high doses of prednisolone until resolution of symptoms, so up to 16 weeks, which was a long time to be on pred. However, although it's responsive, this condition is known for relapsing quite regularly. And if the relapses become too frequent for your liking or for the patient's liking, you may wish to give them immunosuppressive treatment with drugs like cyclosporin or tacrolimus, the calcineurin inhibitor. So this box is a typical case. So usually affects children. So a 4-year-old boy with oedema, they often make mention of frothy urine because of the presence of the protein. And so you have proteinuria and low albumin and edema. So the nephrotic triad, most common cause of pure nephrotic syndrome in a young child is minimal change disease. Next up, we're going to talk about FSGS. This is the most common cause of nephrotic syndrome in adults. And again, it can be idiopathic, or it can be secondary to a number of conditions, particularly IgA nephropathy, HIV, heroin use, so watch out for this in IVDU, and also Alport syndrome, which is a syndrome that affects the kidneys and I think the inner ear. Now, the thing about FSGS is it's glomerulosclerosis that is focal and segmental. And I know that that sounds kind of facetious, kind of stupid, but it is important to define these two terms. So what focal means is it only affects part of the kidney, like the lower right bit or the upper left bit or the middle bit. And even within the part of the kidney that's affected, segmental means that of each glomerulus that's affected, it's only part, only a segment of that glom. So if you look in this picture here, you can see that there is some sclerosis here, and here and around the stalk, but it's fairly normal appearance around about here. And so this in blue is the segment of the glomerulus that's affected by FSGS. If you do electron microscopy in this condition, you find podocyte effacement, very similar to minimal change disease, and there's some debate as to whether FSGS is in fact just a continuation or like an adult form of minimal change disease, and you might also see hyalinosis, which is a further state of sclerosis, hyaline cartilage, Management, again, is very, very similar to minimal change disease with steroids plus or minus immunosuppression. And your typical case here is an adult, perhaps with generalized oedema, so that might be periorbital or ankylodema, and then a pure nephrotic syndrome, so a urine dip that only shows very high protein. So again, pure nephrotic syndrome in an adult is most likely to be FSGS. The next cause we're going to talk about is membranous nephropathy. This one again can be idiopathic or secondary to a number of different conditions, and the key feature of membranous is the presence of an autoantibody against the phospholipase A2 receptor, sometimes called anti-PLA2. Now, PLA2 is found throughout the subepithelial layer of the glomeruli, and so these IgG antibodies bind it there and cause an immune response. They cause immune complexes to form with complement, and that gives rise to deposits of both IgG antibody and C3 complement protein in the subepithelial layer. And you can perform electron microscopy if you like. That will show electron dense deposits, or just dense deposits. Now, the reason they're dense is because there's lots and lots of protein. And also this characteristic pattern of IgG staining called spike and dome. Now, I find that really difficult to appreciate on EM, but if you look here, I think I can show you that it's sort of, the black staining here is almost stripy, almost kind of variegated, and that's what spike and dome staining is. Management of membranous. I have here control of blood pressure with ACE inhibitors or ARBs. Now, really, this sort of symptomatic management is important for all causes of nephrotic syndrome, but the reason that it's here under membranous is because membranous doesn't really have any specific kind of magic bullet drug in the same way that minimal change does. And so really your management of membranous is more just symptomatic. You can give immunosuppression to high-risk patients. There's a query as to whether steroids are really effective, and some people use these older immunosuppressive alkylating drugs called cyclophosphamide or chlorambucil. Again, question marks over whether they're effective. Typical case, I think it would be a bit cruel to give you a question on membranous nephropathy, but be aware that it will present obviously with nephrotic syndrome. And they'd have to tell you something like, the presence of an anti-PLA2 antibody, and if they were being very kind, they might say to you that there were electron-dense deposits on EM and or spike and dome staining. And the last cause of nephrotic that we'll talk about is Mesangiocapillary. This is sometimes called membranoproliferative, or MP, glomerulonephritis, which is quite a helpful name because it actually tells you what's going on in the pathology. Now, this one can also present with blood in the urine, hematuria, and if you remember back to this diagram, it's the one that sits right in the middle here, so it's rather difficult to diagnose sometimes. The reason that it appears here in the nephrotic category is that although there's blood, it does present with the classic triad of nephrotic syndrome, so it qualifies as a nephrotic syndrome. The key feature of MPGN is activation of the complement cascade. I don't know how much you guys remember or like the complement cascade, but essentially it's a bit like the clotting cascade. It's a cascade of proteins, the end result of which is a protein shaped like a donut with a hole in the middle, which wedges itself in bacterial cell walls, and the hole allows the bacterial contents to leak out. So it's a protein cascade that punches a hole in bacteria and kills them, and it's part of innate immunity. So complement can be activated by the classical pathway, which is complexes of antibodies bound to their antigens can activate complement, and this can occur in the setting of a hepatitis B or C infection to cause MPGN. But it can also be activated inappropriately in MPGN, and there is an antibody, an autoantibody, which activates complement, and this is called nephritic factor. The pathology of MPGN is that these immune complexes, and in this case that refers to complexes of complement protein, deposit in the subendothelial layer. This causes the capillary basement membranes to get thicker, and then mesangial cells can come along and send projections into the thick basement membrane called mesangial interposition. And now you have a doubling of the basement membrane because you have a layer above and a layer below, and if you stain for basement membrane you get what's called a tram track appearance of doubled basement membrane. I think that's best appreciated just here on this diagram. That's your tram track. I'm sorry, I couldn't resist doing that. See if you're still awake. So your typical case, I think they'd have to make mention of tram tracking on light microscopy if they were to give you a question about this. All right, so that was nephrotic syndrome. So always remember that it's problems with podocytes leading to leak of proteins, and there's this classic triad of proteinuria, low albumin, and oedema. So we've talked about these most common causes. Just to add one that we didn't talk about, diabetic nephropathy gives you a pure nephrotic picture. Not much more to say about that. And the complications of nephrotic syndrome arise from the types of protein that are being lost. So antibody can be lost in the leaky barrier, and that can leave you relatively immunosuppressed and susceptible to infections. And also some of these proteins, antithrombin 3 and protein C and S, can be lost. Now these normally act to inhibit the clotting cascade, and so actually nephrotic syndrome can leave you hypercoagulable or more likely to clot, and you may wish to treat that with antiplatelets like aspirin, clopidogrel and dipyridamole. So nephrotic done, let's talk about some of the causes of nephritic syndrome. So the most common is IgA nephropathy, sometimes called Berger's. It has a close cousin, which is systemic, called Henoch-Schönlein purpura. And then there's also post-streptococcal glomerulonephritis and anti-GBM, sometimes called Goodpasture's disease. So first of all, Berger's or IgA nephropathy is the most common primary glomerulonephritis. The key feature of IgA is that it's synpharyngitic, and what that means is that it occurs within 1 to 3 days of having an upper respiratory tract infection or a pharyngitis. The pathology behind this is that you produce IgA antibodies to fight the bacteria. However, these antibodies can actually sometimes confuse antigens on the endothelium for being the same as the antigens on the bacteria. That means that when they travel to the glomeruli and deposit there, they can cause an immune response, and this is a process called molecular mimicry. Now, I mentioned that a close cousin of IgA was Henoch-Schönlein purpura, so it has essentially the same pathophysiology, but it's a systemic variant, and the key feature of HSP is a purpuric rash on the legs and the buttocks that is palpable, i.e. it's bumpy. HSP also features a migratory or flitting polyarthritis, so that's joint pain that moves around different joints, a bit like you see with rheumatic fever. And HSP is described as a small vessel vasculitis. That's a concept that we'll come back to in just a few slides' time, so don't worry too much about it. That's the purpuric rash of HSP. And just returning up here to kind of the IgA bit, the typical case preferentially goes for young men. there will be a large degree of hematuria with IgA, and crucially, it occurs within 1 to 3 days of an upper respiratory tract infection. Now, this timescale is vitally important. The reason is that it distinguishes IgA from another cause of nephritic syndrome, post-streptococcal glomerulonephritis, or acute post-strep. So post-strep, by contrast, occurs at least 1 to 2 weeks after a streptococcal infection, and that can be of the throat, a pharyngitis, or of the skin, so an impetigo. The pathology of this one is ever so slightly different. What happens in post-strep is that the antigens of the strep themselves can break off and float away and become deposited in the glomeruli, and there you have basically a normal immune response against them, and this causes formation of immune complexes with complement, proliferation of cells, and also leads to proteinuria on top of the hematuria, which is characteristic of nephritic syndrome. Key investigations for post-strep are blood tests, which will reveal a high titer of this antibody, anti-streptolysin O. Streptolysin O is a streptococcal enzyme, and so the antibody against it just indicates streptococcal infection, and also a low C3 complement protein, because complement is being consumed as part of these immune complexes that are being formed. Management of post-strep is symptomatic. Make sure that you control the blood pressure and maintain kidney function, but also you can use penicillin. Now, quite why this is effective when the streptococcal infection has probably long since resolved is not really clear, but it does work, and so we do use it. Here what I'm doing is I'm picking out the features that distinguish post-streptococcal glomerulonephritis from IgA nephropathy, because as you can see, these are kind of dangerously similar, and it's dead easy to get the two confused. So remember, at least 7 to 14 days after strep infection, that makes it post-strep, post meaning after. Proteinuria on top of the hematuria, that makes it post-strep and not IgA. It's not a feature of IgA. And then these blood results, the low C3 and the high ASOT, are features of post-strep and not of IgA. So here's your typical case. It affects young people. There'll be a nephritic syndrome plus proteinuria, and it occurs at least 7 to 14 days after a sore throat or indeed a skin infection, impetigo. Watch out for that one. And if they're being very kind, they will tell you that bloods reveal a low C3 and a raised ASO titer. So that was post-strep. Lastly, let's talk about Goodpasture's disease. This one is sometimes called anti-GBM disease, and that's fairly obvious why. It's because there are autoantibodies directed against the glomerular basement membrane. Now, specifically, these are IgG antibodies which are directed against type 4 collagen. And if you remember all the way back to sort of first year histology, type 4 collagen is the reticular kind of delicate collagen that forms exchange surfaces, so things where you need diffusion, like in the lungs where you have gas exchange, and the kidneys where you have filtration. And so the anti-GBM antibodies cause damage in these two places, causing the patient to present with pulmonary hemorrhage, which manifests itself as coughing up blood, hemoptysis, followed by a rapidly progressive glomerulonephritis, a nephritic syndrome. And the key investigation is immunofluorescence, which shows linear staining for IgG, which looks a bit like this. Now, what that means, linear, is because type 4 collagen is a key component throughout the basement membrane, it's found in a linear, uninterrupted fashion. Then the IgG, the autoantibody, binds it all throughout the basement membrane, and then when you stain for that IgG, you see this linear, uninterrupted staining. So here it's picked out the whole length, every single part of the basement membrane. That's what that staining means. Goodpasture's is managed by plasmapheresis to extract those autoantibodies from the blood, and then you may also wish to give immunosuppressive drugs like steroids and cyclophosphamide. Typical case of Goodpasture's, I've got here an older male because that's what the questions tend to feature. It's 2 to 1 in men. Do be aware though that distribution is biphasic, so there's a peak in men 20 to 30 years old and then a second peak of the disease in men 60 to 70 years old. So if you're a bloke, you've got 2 chances to get this. Great. Presentation is with coughing up blood and with peeing blood, and there may also be some other respiratory symptoms like dyspnea, shortness of breath, due to the impairment of the exchange surface in the lungs. If they're being very kind, they might tell you there's a positive anti-GBM antibody. I think that would just be giving it away, but there you go. And because Goodpasture's causes a rapidly progressive glomerulonephritis, these patients may first present to you with an AKI. So I've alluded to rapidly progressive glomerulonephritis. I thought we'd go into it a bit more. So it's sometimes called crescentic glomerulonephritis, and what it represents is simply a very fast decline in renal function, the endpoint of which may or may not be an AKI. And a crescent refers to just 2 or more layers of cells that are proliferating within the Bowman's space. And these cells can be anything. They can be immune cells, mesangial cells, epithelial cells, and the reason that they're proliferating is because they're being damaged and needing to replace themselves, and that gives rise to this crescent appearance here. Now, the causes of rapidly progressive glomerulonephritis include Goodpastures, which we've just talked about. Also lupus, which has various autoantibodies against the nucleus and against DNA. I don't want you to worry too much about lupus because you'll cover it properly in the 4th year. But there's also this group of conditions called porci-immune, which means immune poor. Now what that refers to is that in conditions like these two, if you do a biopsy or staining or whatever, you will at some point find autoantibodies that are bound to tissues, definite antibodies that are causing the damage. And you can say that's the culprit. With porci-immune conditions, if you do these biopsies, you don't find any antibodies bound to anything. This isn't because there aren't any antibodies, it's just because they're directed against different targets. These antibodies are called anchors, anti-neutrophil cytoplasmic antibodies, and as the name suggests, they're directed against the cytoplasmic contents of immune cells' neutrophils. And there are 2 different types of anchor. So there's C anchor. Now C stands for cytoplasmic, which means, yep, cytoplasmic is in the name twice. C anchor is directed against a neutrophil enzyme called proteinase 3. And C anchor is found in a condition called Wegener's granulomatosis, or granulomatosis with polyangiitis, GPA. Wegener was a German scientist who first characterized this condition. However, he was a Nazi German scientist, and so we're not supposed to say Wegener's anymore, we're meant to call it GPA. But be aware of both names because of older textbooks, older consultants, etc. And the second type is called P anchor. Now P stands for perinuclear, so this is an anchor directed against an enzyme myeloperoxidase, which tends to hang out a bit nearer the nucleus of neutrophils. And P anchor is found in 2 conditions, microscopic polyangiitis and Churg-Strauss disease. When these antibodies bind to their cytoplasmic targets, they can cause inflammation, damage, immune responses, and that can lead to cell rupture and the release of further antigens into the bloodstream, all of which can produce massive inflammation within the smaller blood vessels where neutrophils tend to reside. And so for that reason, they are described sometimes as being small vessel vasculitis conditions. These aren't the only small vessel vasculitises, and let's have a look at them now. This is something that I always found quite confusing and intimidating as a 3rd year, so just 1 slide summary, hopefully everything that you need to know at this stage. So the first small vessel vasculitis is Wegener's, which we've just talked about, granulomatosis with polyangiitis, so it has C anchor against proteinase 3. And the key presenting feature is a saddle nose deformity, so collapse of the nasal bridge here, and also nasopharyngeal symptoms including epistaxis, nosebleeds, and nasal ulcering too. Imaging of the lungs reveals granulomas, that's the granulomatosis part, and also infiltrates, a bit like you see with TB. And kidney symptoms you know about, crescentic glomerulonephritis, sometimes leading to hypertension because of glomerular damage. Next up we have a P anchor condition. This is microscopic polyangiitis, and this one presents with rapidly progressive glomerulonephritis and also pulmonary hemorrhage in the form of hemoptysis. It features P anchor directed against myeloperoxidase, but also sometimes has C anchors. I know that makes it a bit more confusing, but it's primarily a P anchor condition, so you can forget about that second line. The way I always remembered this was to say that P anchor is directed against MPO, myeloperoxidase, and is found in MPA. And then another P anchor condition, Churg-Strauss. Now this is sometimes referred to as eosinophilic GPA, so they think that it's like this one plus eosinophils. That's obviously very confusing and annoying because it's a P anchor condition, so really it's like this one but plus eosinophils. You guys all know that eosinophils are the cells that are involved in asthma and allergy, and so these patients are often atopic. They present with things like hay fever and allergies, sinusitis, and also sometimes mononeuritis multiplex. So that column there is the P anchor conditions. And then I'm just going to bring back Goodpastures. So Goodpasture is also a small vessel vasculitis. It doesn't have anchors. It's got antibodies against type 4 collagen in the glomerular basement membrane, and it presents with hemoptysis and Crescentic GN, just like MPA does. And so actually these two are frequently differential diagnoses for each other. And I myself actually clerked a patient who had this presentation and put that on my differentials. I think it turned out to be Goodpastures in the end. And then also Henoch-Schönlein, which we talked about earlier. So this one has IgA against the endothelium, and it presents with a palpable purpuric rash, glomerulonephritis, and a moving polyarthritis. So just to ram the point home, these under the purple box are anchor-positive vasculitis conditions, and because anchors do not deposit in the epithelium or in blood vessels, these are sometimes described as being porci immune. So that was nephritic syndrome with a slight detour about vasculitis. So remember that nephritic syndrome is inflammatory damage. There's this loose sort of cluster of symptoms. Be especially aware of hematuria and red blood cell casts. And the causes include all the ones in the red box that we've talked about, as well as the causes of rapidly progressive GN and vasculitis, including lupus, Goodpastures, and porci immune conditions. And these ones in the blue box here are the small vessel vasculitides. Now, vasculitides is the proper plural for vasculitis. So, exam question before we move on. A 22-year-old man has noticed that he's got smaller volumes of urine, which is darker than usual. Not felt himself since suffering a painful sore throat 2 weeks ago. His urine dip shows some protein, some blood, and he's also hypertensive. So this is a nephritic syndrome. He's got oliguria, he's got hematuria shown here and on the dip, also subnephrotic range proteinuria and hypertension. And the killer feature here is that he had his sore throat 2 weeks ago, so that makes it post-streptococcal glomerulonephritis. If that had been he had a sore throat yesterday, that would have been IgA nephropathy. So great, that's nephrotic and nephritic syndromes covered. So we went through the difference between the two. Always remember the nephrotic triad versus inflammation and hematuria in nephritic syndrome. We looked at the causes of each, so FSGS and minimal change for nephrotic syndrome, and IgA and post-strep for nephritic syndrome. And we looked at the typical presentations of each of these. So minimal change has, a child with frothy urine. IgA features it being synpharyngitic, and post-strep, which occurs obviously post a streptococcal infection. So we're nearly there. The last thing they've asked me to talk to you about is renal cancers, and so we're going to talk about renal cell carcinoma, but I know that urology is also a big part of 3B, and so we're also going to talk about some of the bladder cancers, and then we'll round off by talking about myeloma, which of course is a blood cancer, but has many effects within the kidney and also some systemic ones, which I'll tell you about. First of all, renal cancer. So clear cell or renal cell carcinoma accounts for about 90–95% of all renal cancers, and it arises from cells of the proximal tubule epithelium, which have a characteristic clear cytoplasm here. Risk factors for clear cell carcinoma include some tumour syndromes, including von Hippel-Lindau and tuberous sclerosis, and also smoking increases your risk of renal cancer. Renal cell carcinoma tends to present with another classic triad: pain in the loins, where the kidneys are, blood in the urine, and also an abdominal mass. But these cancers can also secrete some kidney hormones, which can give rise to some systemic effects. So EPO causing polycythemia, parathyroid hormone causing an increase of calcium in the blood, renin causing hypertension, and adrenocorticotropic hormone, which can lead to Cushing's syndrome, and also pigmentation, because actually melatonin is the other component which is broken down from pro-opiomelanocortin. I probably shouldn't have said that. It's just, look that up, it's very complicated. Moving on. This is the histology of the renal tubule, in case you get a question on this in your end of year spotter. So the proximal tubule looks like this, the fairly clear cytoplasm. The thin loop has very few cells and very squamous appearance. The thick ascending limb, slightly more cells and a bit thicker. And then the collecting duct, highly organised, many more cells. The key feature here is that the junctions between cells, these lines, are much easier to appreciate, and also central nuclei, so a bit more of an organised appearance. And what I've done here is just colourised our old Nephron diagram to correspond, in case you want to come back and have a look. So now let's talk very briefly about bladder cancers. If any of you have been to cystoscopy clinic, you might have seen one of these. This is a transitional cell or urothelial cancer, and it comes from the cells that form the inner lining of the bladder, and sometimes called umbrella cells because they're able to to stretch as the bladder distends. It's worth knowing the risk factors for the bladder cancers. So the risk factors for urothelial cancer are smoking, working with aniline dyes in the textile industry, also rubber manufacture, so maybe a tyre factory, and cyclophosphamide, which is another one of those older immunosuppressive drugs which we last came across as a treatment for Goodpasture's disease. So be careful when treating your patients Goodpastures that you don't predispose them to urothelial carcinoma. That's the urothelium in health there on the left, and then on the right is it in disease, in cancer. And then the other type of bladder cancer is squamous cell. Risk factors for this one include a schistosomiasis, which is a tropical infection, a UTI that you can catch from brackish, sort of slightly salty water, and also smoking again. So you can see smoking is a big risk factor for all of the sort of renal and urological cancers. And a very quick word on prostate cancer. Another part of urology. So prostate cancer occurs in the peripheral zone of the prostate, shown here in blue, whereas benign prostatic hyperplasia, which happens to all men of a certain age, occurs here in the transitional zone, shown here in green. Now you can see how both of these conditions can constrict the urethra on its way out of the bladder, and that can give rise to these lower urinary tract symptoms. So you get the storage symptoms of urinary frequency, urgency, and nocturia, needing to go at night, and then also the symptoms of constriction itself, so hesitancy, difficulty getting started, poor flow, and dribbling at the end because the bladder hasn't completely emptied, and also painless hematuria. So these are your investigations for prostate cancer. Watch out for the false positives on your prostate-specific antigen. And the reason that the bone scan and the imaging are here is because actually prostate cancer is a key culprit for metastasizing to bone, and particularly to the spinal column, so you want to keep a close eye to make sure that's not happening. You've probably heard the old adage that prostate cancer is one that you die with rather than die of, and for this reason the management of prostate cancer is widely varied, and it can be as little as just surveillance, just watching, but it can go as far as prostatectomy, so removing the prostate if the LUTs become intolerable, and that's with transurethral resection, so TURP and TULIP and those kinds of operations. So lastly, let's talk about myeloma, which is of course a blood cancer, a hematological malignancy, and it's sometimes called a plasma cell dyscrasia. So that's a lot of really intimidating medical words, but remember that all cancers are just, proliferation of a certain cell type to the point where it starts to cause damage to the rest of the body. And in myeloma, it just so happens that this cell type is plasma cells, which look like this guy here. That's it in cancer, so you can see that there's many, many more of them, and they're quite dysmorphic. So plasma cells differentiate from B cells during infection, and they're the ones that are responsible for making and secreting large quantities of antibody to fight infection. So if this plasma cell were to become cancerous, it would proliferate and give rise to many copies of itself. And all of these copies are, of course, capable of producing their own antibodies. So very quickly you have a situation where there's very large quantities of unwanted antibody in the bloodstream, sometimes described as paraprotein. If you run an electrophoresis of this person's serum, what you will see is a very thick, dark, what's called a monoclonal band in one region, one antibody. Now, it doesn't have to be IgG, it can be IgA. But the key thing here is that it's only in one specific location because all of these antibodies are identical because they all come from copies of this one original cell. Now, the other effect of this large-scale antibody production is that these antibodies can start to fragment into their components. If you remember, they consist of heavy chains and light chains, and the light chains can actually break off and float around. They can deposit in the glomeruli, and they can actually appear in the urine. If they're found in the urine, they're called Bence-Jones proteins. I think the reason behind this is that Mr. Bence-Jones discovered this protein before we even knew what antibodies and light chains were, and so he named them after himself, and then it just stuck. But just remember that Bence-Jones protein is exactly the same as antibody light chains, and it's a sign of myeloma. If you guys are wondering what this kappa band is, light chains are characterized as either kappa or lambda, and so the kappa band is actually just the light chain band precipitating out here. Clinically, you can remember the features of myeloma using this mnemonic, old crab, which I find really, really useful. So old refers to over 65 years. The mean age at presentation of a patient with myeloma is 70 years. C is for high calcium, hyperkalaemia. R is for renal failure because of these protein deposits, especially the light chains causing AKI. A is for anemia, which is a feature of all blood cancers. And B is for bone lytic lesions. Now, the reason for this is that the antibodies that are being made are actually able to activate osteoclasts, and they cause resorption of bone. That's also the mechanism behind the hyperkalaemia, because calcium is being extracted from the bones. And the investigations I've already mentioned, so electrophoresis, which will show a monoclonal band a bit like this one, and also urine for Bence-Jones protein, which of course is just antibody light chains. So if you ever get a question on myeloma, they tend to present with quite unusual, seemingly unconnected symptoms. Just be aware that hyperkalaemia sometimes presents as paresthesias, numbness and tingling, stuff like that. And if you see an odd question with symptoms that you can't quite characterise, use old crab as kind of a screen. See if they've got any of those, and it's probably going to be myeloma. So let's take a look at one of those together. An 80-year-old man attends his GP with persistent mid-back pain. Blood tests reveal a high calcium and low white blood cells. What's the most appropriate thing to do? So, of course, you know this is a myeloma question, but if you didn't, he's old, he has bone lytic lesions, high calcium, and not really anemia, but close enough. And the most appropriate investigation here is, of course, electrophoresis. And there is another test that you could do, which is that urinary Bence-Jones protein to look for light chains. All right, so that was renal cancer. So we looked at renal cell carcinoma, how it's derived from clear cells, is a feature of von Hippel-Lindau and tubular sclerosis, and we looked at the classic triad. And then bladder cancers, we looked at transitional cell, squamous cell, and we also even looked at prostate cancer as part of urology. And then myeloma, we talked about what it means to be a plasma cell dyscrasia and the clinical features, which can be remembered by this mnemonic, old crab. And that's everything. So well done, everyone. Thanks for sticking with me. Way back at the start, we covered renal control of acid-base, and then we had a look at hyperkalemia, nephrotic and nephritic syndromes. Hopefully you're a whiz at diagnosing those now. And just talked about renal cancer. This here is how I was taught that Nephron diagram by an F2 in the Royal London just on a flip chart. And so I wanted to include this photo from my phone just to show you how knowledge gets passed on. Hopefully you'll want to pass some of this on yourselves. So thank you very much for your attention. I really hope that you're all staying safe and well and sane. And do email me. My email's on the first slide. If you have any burning questions, I'll do my very best to answer them. But for now, thanks very much and goodbye.